Hello, everyone, and thank you for joining. This is Dr. Labasi from 3D Diagnostics. I would like to welcome you to session 4 of 3DX series of educational webinars. First of all, I'd like to wish you and your loved ones all the best in health and wellness. Now, a few technical points regarding today's session. A code will be given at the end of today's lecture for CE credit, along with the details required to claim it, and also an email will be sent to all attendees within a few days with the CE certificate. Also, please feel free to add any question you would like to ask in the Q&A box, and it will be answered either by one of the panelists during the session or by Dr. Engel at the end of the webinar. Any unanswered question will be answered by Dr. Engel and sent to you by email within a few days. So, that being said, today's webinar is about guided full mouth rehabilitation, and we are so fortunate to have our presenter today, the founder and president of the Engel Institute, diplomat of the ICUI, a pioneer in education of implant dentistry, especially guided implant dentistry, one of the most knowledgeable super GPs in the field, and frankly, my personal mentor, Dr. Todd Engel. Dr. Engel, the mic is all yours. Thank you.
Hello, good afternoon, everybody. I believe we are trying to get the video up. Frank, it says that you can't start the video because the host has stopped it.
All right, let me, yeah, there you go. I think you're the host now, and you'll be able to share video, Dr. Engel.
Okay. All right. Good deal. Hi, everybody. I hope you're all doing well. I can't see me, but I think you could see me. So that's good. Let me just try to do one more thing here. Okay, well, we'll just go with that. Well, welcome. I know that we are in the midst of kind of hitting a different tempo, so to speak, as it relates to the climate of everything that we're going through. So I'm hoping that you guys are feeling a little bit positive, as I am, and keeping up the good spirits. And hopefully this stuff will be behind us soon, and we'll be well on our way to doing what we love to do. So that being said, I hope that you're all safe and sound. I hope that your families are all safe and sound. Give me a moment. I'm getting some info here. Can you guys see me okay? Okay.
Yes, we can see you. We can see you perfectly fine.
Great, great, great. Okay, so I'm just going to go ahead and start. Again, as I was saying, I hope that this time finds you well. I hope that you and your families are safe and healthy. And I'm really looking forward to today. You know, it's interesting because this downtime, so to speak, has been really incredible for me. As an educator, I get to really dive into some deep stuff and work on being, you know, just that, a better educator. So I hope that you enjoy the time today. I have put some really nice things together for you. And that being said, we're going to start. So what you're looking at here is this is my dental center in Charlotte, North Carolina. I'm a GP, as many of you probably know. My practice now is limited to surgery, so I don't work on teeth anymore. And what you're looking at here is a combination of a clinic and an educational center. So you'd be sitting in the classroom with your view right now. And the view that you see is 7 operatories where we treat our patients Monday through Wednesday, and I do half of Thursday if I'm not doing a course. If that's the case, then I'll do Monday to Wednesday. But nevertheless, I have a passion, as you're going to probably see if you haven't already seen me speak before. I have a big time passion for what I do. I have a big time passion for results, but I also have a big time passion helping people like you do better if I'm able to. Now, when 3D Diagnostics asked me to do this, and by the way, I'd like to thank all of them. Frank, thank you for that wonderful introduction. The CEO, Khalid, I'd like to thank you and all the guys over at 3DX that helped us. They said, you know, people like listening to you, and you're an implant guy, and could you do, something on full mouth guided surgery? And I said, I'd love to. Now, that being said, I know that, social media is blowing up right now for a lot of good reasons. That being said, let me just switch this slide real quick here. So following the presentation, we're going to get a lot of questions. I'm sure there's several hundred people on. And a good way to reach out to me if you have a question is Instagram. I'm on Facebook somewhat, but I've been leaning towards Instagram lately because it's very dentally related, and that's kind of what I'm into it for. So there's my little handle there, Todd Engel, DDS, and feel free to ask me any question that you'd like. So if any of you have seen me speak before, I'd like to think of myself as a conservative educator in that whatever I teach, I want you to be able to understand and or implement. So what I mean by that is if everybody has an understanding of what we're trying to accomplish, that's great. If some people feel that it's apropos for them to go and provide that care, that's good too. And maybe others might feel, you know what, I'm really glad I learned it, but I don't know that that's my thing. I don't know if that floats my boat or if that's something that I can do. And that's fine. I am not here to try to make you do any care or try to make you do treatment that you're uncomfortable with. It's just to give you an understanding. So that being said, we have quite an audience with a very, very vast amount of knowledge, surgical intellect, surgical acumen, technology, skills, tenure. There's a lot of things that go into a surgeon. So what I've done is I've streamlined this to be conducive for anyone, whether it's you doing a few implants a month and wanting to dive into surgery more, or I know that I've got some oral surgeons on here, and so we're going to keep them excited and interested as well. Now, that being said, a question that was asked of me, I did a panel meeting Thursday, which I'm sure some of you have seen, and one of the questions that was asked to me was, am I held to the standard of a surgeon being a GP? And I would just like to say something regarding that, and then we're going to hop on in this. It doesn't matter whether it's your first implant or your 20,000th implant. As soon as you lift up a drill and you drill in someone's jawbone, you are a surgeon. So my recommendation is to work at your craft every single day, like it's a language, as I do. I'm a GP who's done pretty much exclusively implants for the last 15 years. I think I have about 25 or 30,000 under my belt. And I just say that because even though I've done a lot of implants, I still take every case very humbly. And I look for all of the things that are in the case that could want to get me, so to speak. To date, I have probably done about 600 or 700 guided surgeries. And right now, that's pretty much what my practice is limited to, full arch guided surgery. So know your stuff, okay? That's basically the message there. Okay, so if you haven't seen it, if this is the first one that you're watching, I did do an intro to computer guided surgery that you can find on YouTube. So just type in that title or my name and it should come up. And I think it was really, really good. I thought the basics were pronounced really well. And I think you'll enjoy that. Okay, so today what we're going to do is we're going to do full mouth guided rehabilitation or full mouth guided surgery. Now, it is really important that you understand that no matter how easy someone makes this sound, that's not the case. Like I always say in my implant courses, it's really easy to put an implant in the jaw. It's just all the other stuff. So even though this picture shows you all these different pieces stacked together and oh my gosh, look at that, the teeth are going to come out perfect. There's a lot that happens in between all of these steps and all of this stuff. All right. So we've all done this. We've all taken an Uber, right? And I like to kind of correlate it to just that. So you fly somewhere and you decide when you get out of the airport that you want an Uber. Or let's take it a step further. So I practice here in Charlotte, okay? Right where you see that black arrow. Now, if I want to ride somewhere, I have to tell Uber where I'm going, and then I get directions, okay? So the two most important things are where I began and where I'm ending up, okay? Because if I don't know where I am and have all the data, the airport, the gate number, which door, which terminal, Uber's not gonna come get me. And the same is true where if I don't tell Uber where I'm going, I'm not gonna get there. So throughout all of this, you're gonna hear that the most important thing that you can do is visualize the results before you start. And we're gonna talk about that. Okay, so let's dive in with Bobby. Bobby is a case that came to me probably about 4 or 5 years ago, and she experienced quite a bit of trauma. This actually turned out to be a central incisor root canal, and she had all of her teeth, maxillary teeth, and whoever did the root canal perforated the tooth, placed a good portion of the gutta percha into her nasopalatine canal, and so she had indefinite burning. She went through a 1.5 years of burning before anyone would believe her that she was indeed experiencing this. So what they did was they first told her it was psychosomatic pain, and they put her on something called Neurontin, which is a mean drug. Then after they realized with various tests that it maybe wasn't psychosomatic, they removed all of her teeth because of one bad root canal that nobody could detect. So when the case came to me, there was a lot of litigation going on, and I took it over from there. And what we did was I actually immediately figured out what was going on, that she had perforation into the nasopalatine. And what we had to do was we had to resect her nerve. Okay, we had to resect her nasopalatine nerve. But look at this. This is how I met Bobby, okay? Bobby came to me with no top teeth, no maxillary teeth, still burning in her maxillary jaw, and we resolved that by a nasopalatine resection. But here is her sinus, or her sinuses, okay? And here's the ridge of her jaw. Not bad, not bad at all. If this is a panel view of a 3-dimensional X-ray, so it's a flat image. But height looks good, right? So if we've got width, we're in good shape. All right, so as we go towards the posterior, we start losing a little bit of height, and that's okay. We're gonna talk about how to deal with that. Now, when you're talking to your patients about preservation, if you will, before you take out all the teeth and watch the sinuses pneumatize like this, it's really important that you explain to your patients before the teeth come out that teeth roots are like tent poles, okay? And if any of you have ever been camping, what would happen if you were laying in the tent and the poles got pulled out? The tent would drop. So these are some of the things that we need to explain to our patients prematurely, before. We always say it's a lot easier to be conservative and fix it sooner than later. Okay, so here's Bobby, and when she comes to me, she looks like this visually, and she says, I hate my denture. My denture won't stay in, and I want something fixed. Okay, now, at the bottom here, you're gonna see this little light bulb guy. Okay, you're gonna see this little guy pop up periodically throughout my lecture. And when you see that, I'm gonna give you a big, big pearl, okay? These are points that you just simply can't forget. Whether you're a GP, perio, pros, oral surgeon, there's just some things that go with every case regardless of your title. Now, here's the learn here. Low-hanging fruit. And what I mean by that is when a patient comes in like this to your office, okay, namely as a GP, because if they're going to a specialty, the procedure has probably already been indicated. But this part, especially for a GP, but it could be for everybody. So when I said to Bobby, you know, what's the problem? She said, I just hate this thing. Pounds and pounds of glue, it won't stay in. I just need something that stays in. Now, I had just met her, okay? And what I wanted to do was I wanted to make sure that I gave her a really good experience. So when I say low-hanging fruit, guys, here's what I'm talking about. When someone comes to your practice, okay, and you feel that you have the ability and the willingness to care for that person, Find the thing that you can fix the quickest that would make the biggest difference to them. So for me, what was that? Well, I'm going to ask you a question. Excuse me, 1 second, my alarm's going off. So I'm going to ask you a question. What do you think Bobby misses most? Her denture won't stay in, it's loose, she needs something that stays in. Well, Bobby wants to eat, right? So if I know that the denture won't stay in, I'm gonna figure out why. Because if I could figure out why the denture won't stay in, this is gonna help both of us, and the relationship is now solid. Very easy to do. So low-hanging fruit first. I noticed that her frenum was very, very low. And after looking at this and evaluating that it was 5 millimeters, I knew that nothing was going to stay in. Every time she moved her mouth, the thing would fall down in the front. So the very first thing I did was I told her, Bobby, we need to make that a little taller for you. And that's going to allow the denture to stay in. So with a diode laser, I went in there, I resected the frenum, and in one appointment, we went from 5 to 12. What you're looking at on the bottom is about a 1 week, 10-day post-op. So now I could at least keep her denture in. Yes, she had to use 15 pounds of glue, but at least we could keep her in and she could eat, which we all love to eat. I haven't eaten yet today and I'm hungry. I want to eat. If my teeth were loose, it would be really frustrating for me. So what we did here for about $225 is we created a way to make the denture stay in. So the pearl here is when a patient comes to you, find the quickest way to make the biggest difference. Does this make sense? The quickest way to make the biggest difference. I couldn't make her a new denture in 1 day that was perfect. I couldn't make her a new denture in 1 day that would stay in her mouth without glue. I wanted to, so to speak, win her over to be my friend, to be my patient, confidant, to where she would trust. So this first step was huge, huge. She was in, okay? All right, the next thing I did was I evaluated her denture. Now guys, for those of you who have surgical experience, or those of you who are coming in, a denture wearer is by far the easiest patient to work with as it relates to full mouth guided surgery or full arch guided surgery, because they already have their teeth gone. So the biggest dilemma that all these people face when they're going through treatment is, what is the transitional phase like? Which we're going to talk about all this. So this is a decent looking lady. She was quite becoming. She just had lost everything about her, right? She was very active. Great husband. I met them both. She had a lot going for her. But something like this is a big setback and can really, really work against your psyche. So I put in her denture and I started evaluating things. Her pupil line. So her teeth were canted to her left. Then I looked at the midline. I'm half a tooth off. So what I've done here is I take an impression, okay? And I'm gonna walk you through all these steps. Take an impression, okay, using your denture. And I have my lab just do a really, really quick new denture that matches up her pupillary lines, okay, and gives us a nice becoming incisal edge. These teeth are too square for her. It wasn't perfect. But what we did was we set up her VDO, okay? Now, if you don't know how to set up the VDO, that's okay. Have someone work with you and help you. Guys, there's the light bulb again. I'm telling you, this is the biggest problem. Number one problem right now today is people going in and starting surgery before they know where the teeth are going to be. It is a disaster, and I guarantee you won't come out of it every time. This is a promise. So, light bulb number 2, create the desired prosthetic plan before you start your surgery. Now, this is close. It's not dead on. I'm going to probably give her taller teeth, thinner teeth, pretty it up a little bit. But her jaw position and her VDO and everything is correct. Now, she doesn't want to do anything to the bottom teeth now. She's had a nightmare with the top teeth. So what we're going to do is we're going to make something as you see it to be our kind of template moving forward. Okay, so now that you've met Bobby, let's go into the protocols of how this is done, okay? I know that for some of you, this might be a little bit of a bore, but I have to visit this and I'll hopefully do it quickly and painlessly. Hang on. My coffee. Okay, so we're going to talk about something called the dual scan protocol. And for those of you who are climbing into this type of surgery and haven't done it yet, this is the fundamentals of all we do guided surgery, okay? Dual scan protocol. When I started doing guided surgery about 15 years ago, I actually think I was the first GP in California to do it. We had 3 scans. And now with all of the technology, which has grown so quickly, we now have mastered this down to 2 scans. Now, one of the things I always say in my guided surgery courses is this. You guys, guided surgery is not intended to replace knowledge, okay? It is not intended to replace knowledge. Guided surgery is intended to facilitate the prosthetics. So in other words, if I line up my teeth right here where you see them, I need implants to go under teeth. So what guided surgery does for me is it facilitates the positioning of the implants under the desired prosthetic plan, as you could see here. When we are doing these kinds of cases, we do not want to have implants in between teeth. Now, there is an asterisk, an exception to that, and I'll get into that later, but remember this so far. Get the lowest hanging fruit on the patient, become their friend fast, get them comfortable, get them able to eat, and then the second thing is we have to figure out a way to set up the prosthetic scheme. Okay, so here's Bobby when I met her. There's Bobby now 5 years later, okay? So there she is, okay? This is a titanium bar, acrylic wrap hybrid, and she chose this because of maintenance. We went over everything, which I'm gonna talk about. We talked about maintenance, we talked about cost of maintenance, we talked about annual visits, etc. And when the prosthetics are done correctly, these are actually quite nice. My tendency is to gravitate towards zirconia, but after explaining everything to her, she had chosen the titanium acrylic wrap. But anyway, take note of this. So we have a couple tilted implants in the back. We have 4 implants that are straight up and down in the front. You're looking at, again, a round object, a human, on a flat image. So it's making them look tipped, but they're straight. Now, I'm going to close this by saying this. Here's Bobby on the left. Now, if you look at Bobby on the left, okay, on your left, her eyes are defeated. Her cheeks are defeated. Her mouth, her teeth are off to her right, as I mentioned. Now, when you look at Bobby now, 4 years later, I mean, look at in her face, the life that we have created in this woman. So it's interesting because when I talk about full arch, full mouth surgery, whether it's a single arch or a dual arch together, I really never focus on the money part. I just don't. I focus on what will it take, what is the artistry needed to execute what I think I want to execute. And does that work for the patient? And we're going to walk through that, okay? So I want to leave you with this as far as this part relates. You must be able to see the results before you start, okay? This is the biggest gift I can give you if you're new to this, all right? So let's talk about full arch surgery. And I'm going to say guided surgery because that's what this is about, full arch guided rehabilitation. And I do singles and I do doubles and I do doubles together. I do IV sedation. For those of you who are doing big surgeries and you don't have IV sedation, I would highly recommend that you look into that because it relaxes everybody. Obviously the patient's snoozing and it just makes it easier for you, and the memory of what happened afterwards is also very minimal as well. Okay, so when we look at a patient, for the longest time, I studied transition lines. I studied smile lines. I studied when do we need to do a hybrid versus a tooth bridge, et cetera. And it's very, very clear. So let's go over some of these. Now, I'm going to skip through some quickly because we have an hour and 15 minutes, okay? So, but here's some pointers, and this also will be on on YouTube. So if you want to go back and get it. Okay, so the question is, what are we replacing? And I'll show you what I mean by that in a minute. So some of the considerations are, one, what are the patient's expectations, just in general? Be a listener here, and I'm going to give you 3 questions to ask them and listen to them. Take your gloves off, take your mask off, get out of doctor mode, and be the doctor psychologist, and just listen to them and let them speak. Okay? Are there any adjunct procedures as you gather your information? Do you need sinus lift? Do you need tissue grafting? Do you need extractions? Look at the whole thing as opposed to just 12 teeth on implants. What else is needed? Okay. Are there existing limitations? Maybe one limitation that people often overlook is the health of a patient. And I'm going to show you in a little while how it is imperative that we work on healthy people to increase our successful results. Maybe the patient has dexterity issues. It could be a number of things. What are those limitations that we're looking at? Maybe it's funds. Maybe it's they refuse to take anything in and out of their mouth. It could be a lot of things. How many implants are you putting in? I'm going to show you that 4 or more, when it's integrated, it's all the same. Now, personally, I always put 6 on the top and 5 on the bottom, but this is not perfect for everybody, and it doesn't mean that 4 won't work. And we're going to go through the number of implants in a little while. The final prosthesis. What is the final prosthesis? Because as you're going to see in a minute, we have to design everything differently based on the materials that we're using. Okay? Now, the position of implants. We have different forces in the jaw, and I'm going to go over 3 different parts of the mouth that are very different as it relates to forces. Excuse me, my alarm again. Okay, so the next thing is the AP spread, okay? The AP spread. We're going to talk about how, when this concept of immediate load first started, how we have gravitated to where we are now. The AP spread was very, very different when this all started versus how it's looked at now. We're going to talk about cantilevers, etc. And then, of course, the end goal. Excuse me, 1 second. Back. Okay, and the end goal, okay? Sorry. Okay, so let's look at considerations and the initial exam, okay? So the initial exam, what are some of the things that I talk about at the initial exam? Number 1, I asked this patient, sorry, I was just running. Am I the first person you've seen for this? The second thing I'm going to ask, do you know if you'd prefer something fixed or removable? Now, let's go back to question 1. If I ask a patient, am I the first person that you've seen for this? If they tell me yes, I know that the appointment is going to be a little deep. We're going to talk about a lot of things. We're going to talk about options, money, and this could blow them away. We're going to talk about time. We're going to talk about a lot of things. This is a really important question to ask first, because if you're not their first person, somebody went through all this with them. So lots of times someone will come in and we'll sit down and I'll say, so what brings you in today? And they'll show me their mouth and I say, I see. Okay, how can I help you? They'll say, well, I'm here to get new teeth. And I'll say, so am I the first person that you've seen for this? And if they say no, there's a high probability that they either saw another dentist or maybe even went to Clear Choice, which is doing a fantastic job at promoting this treatment. And if they did go to another dentist or Clear Choice, I know that money was discussed. So my posturing's a little bit different. So the first thing I want to know is, did someone break the ice to them about the treatment, about that maybe they need all their teeth removed, or they're going to have to spend $25,000? It's a very, very important question. And then the second thing, do you know if you would prefer something fixed or removable? Now, if I'm their first initial visit, they won't know. So I'll help them. You should have models. You should have a hybrid model, a screw-retained model, and you should have an overdenture model. And you should show it to them. And you should tell them, tell them how it works. This one has to come out, this one stays in, etc., and walk it through them. Now, if someone says to me, what would you do? I would say, based on my knowledge with what I do and based on the results that I've seen with the patients and their satisfaction, there's no question that I would do something fixed. The younger that they are, the more I will push them in that direction. And lots of times it's dictated by finances. And I understand that because the treatment can get quite costly. And this is where third-party lenders come in. But if we remove the money part and we just go to what would be better, it's a very, very obvious difference, not only for aesthetics and everything else, but for preservation of tissue, long-term preservation. So I would always recommend something fixed, okay? And if the budget will not allow them, then they can certainly go with something that is tissue supported, implant retained. Now that's a big deal, and we're gonna talk about that. Okay, and then if they haven't seen a dentist, I will say, okay, do you have any idea as to what your investment might be? Because this is a very, very important question, because someone might say, well, I'm guessing $20,000 or $30,000. Then they're pretty realistic with what is going on. If they say, well, I have $2,000 in insurance and I have $1,000 in cash, your posturing should be a little bit different. Like, you might have to let them know gently. So these are 3 questions that I ask every single new patient that comes into my office for full arch or full mouth rehabilitation. Am I the first one? Would you prefer something fixed or removable? And do you have any idea what your investment's gonna be? Now, the other thing that I do when they come in is I say, okay, look at it this way. Look at it like you wanna, I'm your real estate agent. I tell them, I'm your real estate agent. Do you want a single family home? Do you want a ranch? Do you want a mansion? What is it that you want? And the finances will dictate me to help you. So that's worked as well. Okay, the power of 3, we're gonna talk about that. People love things in 3. Starbucks is a perfect example of that, the gas station. We know that there's power in 3, okay? And you should look that up. All right, so let's get into the appointment. Have faith in a 2-part presentation. Trust yourself. And the reason I'm saying this is because this is a lot of detail to put into every single consultation. So when a patient comes in, I actually have no gloves on, I have no mask on, my chair's turned around, I'm leaning against the back, and I'm trying to make it a little bit casual. And I just say, okay, so talk to me, what brings you in when you could be at the beach? And they tell me all their issues, or they don't tell me all their issues, but we go through that. And so what we do is we, obviously we'll do a CBCT scan, and we will do some 4x2s, and we'll take some impressions. And what I tell them is this. I say, Lisa, it would be unfair to you and to me to try to give you all of your options right now, because this is a very, very comprehensive case that took you a long time to get this way. So if you're okay with it, what I'd like to do is I'd like to do a few things now and a few things later. And they like that. They don't feel pushed. Now you have to trust yourself, and it's gonna work, okay? Number 1, obviously get all the radiographs, get your study models, and get some good photos. I don't wanna go into too much, you'll see my photos, what photos to take, et but just give yourself something to refresh, okay? And these cases you should be documenting all the way through, if nothing else, to learn. But if a patient comes in and then a week later you're trying to remember who it was, photos will really help. So you tell the patient, Lisa, I'm gonna take all of these things and I'm gonna sit down in isolation for an hour or so, and I'm gonna create 3 options for you. Now guys, that's the power of 3. Good, better, and best. Okay, good, better, and best. And I'm gonna provide those options to Lisa. Okay, so I'm going to present the case at appointment number 2. My strong recommendation is that it's within 10 days. Don't let time kill. Okay. Offer them a good, better, best. And the other thing, which is huge, is tell Lisa, whoever your significant other is, can you bring them in? Well, I don't have a significant other. Okay. Anyone that you might feel like you would want to complain to. How's that? Can you bring them in? Because I think it's really important for them to hear all of this from me, because as patients, we tend to hear things the way maybe that we want to. And I think it's really good for that person to come in and support you. All right. Now, this is huge. Okay, guys, feast your eyes on this. I, ad nauseum, bury this into their brain that as soon as we start, that they have to eat a diet as though they didn't have teeth. So anything that you could eat without teeth, you can eat. Because as you see in the lower left, micro movement is your killer. Okay, and we're going to talk about torques and all that later, but micro movement is your absolute killer. So they should be able to mash the food, put the bolus to the roof of their mouth, and swallow without choking. Okay, there's some things in the image that might be a little bit harder, but people ask me about hamburger. Sure, cut it up. Eggs, cut it up. Cheese, cut it up. Protein is really, really, really good for healing. So egg salad, tomato salad, tuna salad, all those types of things with protein is going to help heal quickly. And of course, fish is great. Okay, so let's talk about immediate load. Okay, we have come since the 90s, a long, long, long way since Brent introduced the concept of immediate loading. Now, functional loading immediately follow implant placement. They essentially, the idea was behind it was it had no healing period, meaning the patient would theoretically go unchanged. Potential less trauma to tissue. There is no better time to put in an implant and to put a tooth on an implant than time of surgery. It is much better than two-staging it. Now, I'm not saying that that always can happen, but if you're going to cut something open, drill a hole, there is no better time to put in the implant and the tooth. You are in a better surgical position than you will be, and you are in a better prosthetic position than you will be, most likely, okay? Now, decreased treatment treatment or treatment time. This is really big, especially coming out of this COVID. One of the things that I'm going to be doing is I'm going to be talking to patients about how it's going to require less appointments if we strategize it this way, removing teeth and doing the treatment that I'm going to show you. And I highly recommend that you look at that too, and you talk to your patients about not only less treatment time, less appointments, but also when we get back in 2 or 3 or 4 or 5 weeks, we're going to be mandated as to how many people we could see. We will not be able to see them back to back to back and have them sitting in our reception rooms anymore. Those days are over, at least for the short term, okay? The next thing is we have to talk about when those implants go in, what is the bone implant contact? And this is all what the immediate load strategies were predicated on. Okay, so in 1988, Cosimo did a study on surfaces and which type of surfaces would be conducive for these types of treatments, okay? And what we understood was that an uncontaminated or a non-contaminated, and what we talk about contaminated, nothing is contaminated out of the package, so what site is it going into? So he studied and showed that in an uncontaminated environment, if you used an implant that had a treated surface, you had more advantages to bone growth, to stress transfer, and to bone implant contact. And here it is right here in the Journal of Biomedical Materials. A few years later, Carlson came out and published something, said, there is no question on a non-contaminated, okay, non-contaminated, this is a virgin site or something close to it, non-contaminated site with a treated surface implant, that the bone forming cells on this rough surface was far superior than something machined. Okay, so as we look at surfaces, it is really, really important that we understand that there's a lot of things that play into the success of full arch surgery. Obviously the patient, right? The type of prostheses, the occlusion of the prostheses, and a number of other things. But the new roots or the imaginary roots, or there's a word I'm missing right now, but anyway, the new roots that are going to put in, which are the implants, something is said, has to be said to what we're using as well. So if you look here, hydroxyapatite implants or machine surfaces were kind of the first generation. And when Brannemark came out with this immediate load concept, he was going into a second generation surface, which was a treated surface. At the time, it was called Ti-Unite. Now everybody has a treated surface. And what this basically means, it's an SLA surface, which is a sandblasted large acid etched molecule that goes and penetrates the surface. And what this does is, I explain it like walking on the moon. Like if you were to walk a straight line in your living room from your wherever you are to your door, it'd be 12 steps. If you took that distance and you put it on the moon, you'd be walking in and out of crevices, so you'd have to take more steps. So this is what I mean by an increased bone to implant contact, because you have more surface area that's touching. Okay, we are now working on a third generation surface, a nano surface. Right now, as we see it, there is very little to no difference yet. Stay tuned for that. So what's the take home here? There's a lot of things that go into full arch surgery other than just, does the patient have money? Does the patient have bone? Do the teeth look pretty? We have to make sure that we're using an implant that is conducive for that. And I think we're in great shape. Okay, so if we were to look at surface topography of a machined implant versus one that was that had surface texture, as you could see here in the SEM, the machined one at the top has a very smooth surface, so the bone implant contact and the retention, initial stability, and the ability to hold a full arch prosthesis is not as predictable as something like the one on the right. That's a BLX by Straumann. This is treated. The threads are very aggressive in a good way. They taper down towards the bottom. We have a conical fit neck that tapers in towards the top of the implant. So this design has really given us advantages towards full arch care. Okay, and then lastly, when we talk about sandblasted versus, as I mentioned, machine, you have a higher bone to implant contact, which is better for cell occlusion. Now remember, this has to be in non-contaminated or uncontaminated sites. So we've spoken about the implant surface. Okay, now, so when we talk about immediate load, success includes many factors, including the physiological state of the recipient, which is overlooked way too much, the health of the patient, diabetic, et cetera, okay? Smoker, all right? Placement procedures, so how are you doing? How are you placing it? Are you in a sterile field? What type of surgical agendas are you implementing? The materials, design, and surface of the implant. So there's a lot of factors. It's not, do you have steady hands and can you drill to 12 millimeters and can you put the implant in? There's a lot of factors that actually can help you or hurt you that are out of your control. Okay, so here's Brent. Brent came to see me about a year ago, and it says, what do they want? Now, Brent had a lot of challenges, and one of the things that I have found with these types of patients, and I see these guys 3 or 4 or 5 of them every day, they don't really dread the procedure. They don't really dread what the procedure is going to be like for them right after surgery. What they dread is the transition. They just absolutely cannot fathom having a denture in their mouth with glue. So one of the things that I like to speak to the patient about is, if we take this approach, your transition of care is going to be quite easy for you. The only thing that's going to be challenging is it could be a diet, right? It could be the type of food you're eating or will eat. So this is how I met Brent. And in one procedure, we took Brent from what you see on the top to what you see on the bottom. And this is literally one appointment. You're looking at his PMMA upper and lower, screw retained temps. And this is how he walked out. It was just an amazing transformation. Okay, so let's talk about how we do this. Now, the one biggest thing that I've learned, and I'm going to show you a case that I inherited that went really, really bad. we have to evaluate the smiles of the patient, and we have to evaluate the incisal edge of the patient. So I'm going to show you 3 different smiles, and this is really going to dictate how we treat the patient, prosthetically, aesthetically, etc. Now, the incisal edge position of teeth dictates everything, you guys. You have to start with the tooth setup, because the incisal edge position it's kind of like crown down. Set up the occlusion, consider what type of materials you're going to use, and then design implant placement based on that. Okay, so here is a very, very nice looking zirconia full arch bridge. And what I want to point out here is the transition line. Now, this line this can make you or break you in a very, very big way. This transition line should not be able to be seen when the patient is smiling. Now, that's a little bit more difficult than it may seem, okay? So I want to show you how I look at this and how I adjust accordingly. So here's Dan. Dan came in, and I want you to look at his smile, okay? We started on his top arch. We're going to get to his bottom. So look at his eyes here. He's got very, very defeated eyes. Now, I'm going to show you which 3 photos I want you to take, but I want you to notice the position of the eyes. When you go to his mid-face, his cheekbones look a little bit almost pointy. And the reason that they look pointy is because he has a very protected smile. If you look at his smile, you can't even see his bottom teeth. Now, they work round down a little bit, but this is his smile. So when I look at this patient and I look at his lower lip line to his chin, this is the dimension I have, okay? Now, this is the guy that doesn't know how to smile. Now, let's look at him here. The eyes look different, okay? What's gonna happen is as the patient smiles more, the eyes are gonna start to close, because the muscles push up, and it tends to make the eyes close a little bit. If you look at his cheekbones now, they're a little bit more relaxed. But look at his smile. Yes, we made his teeth longer, but I want you to look at now the lower lip line to the chin. So here's the point of this. You guys have to make sure that you prepare for an individual who is somewhat in a smile depressed mode on the left, to the smile mode on the right, which is smile proud. And if your transition line is too low, this could be a very big deal for you. So let's look. Okay, here's a patient of mine, and I want to show you this because I'm going to show you that, as you probably are aware, some patients don't even know how to smile. Okay, so as you see here, I said, Ken, smile. And I came up with my camera and I took a picture, all right? Look at his canine, okay? I said, Ken, come on, give me a smile. This is his canine. I said, Ken, smile like you won the lottery, okay? And here's his canine. Now, this was in the matter of 5 minutes. So you have to have your patient give you an exaggerated smile. So let's look at that. And the reason he didn't smile is because this was his mouth. I couldn't even get in to take a picture, really. Okay. So let's look at the transition line, okay? We have to decide with the transition line whether or not we have what's called a composite defect or not. So on the left, you see a composite defect, which from patients number 7 all the way around to 14. So for those of you who are in Europe, we're going to call it 1-1 and 1-2, and then 2-1 to 2-6 on the patient's left. A composite defect, it means as I'm going to replace this, what am I going to replace it with? Am I going to use something pink, or am I going to use just white teeth? So sticking to the image on the left, this is obviously something that I need to replace with pink. So if you need pink, or you need to replace papillas, this is a composite defect. This is where I would strongly recommend that you consider going to a hybrid, okay, which is an acrylic over titanium, or a zirconia bridge, something that you could replace the tissue. And I'm going to show you in a second. Now, the case on the right, we have a little bit of a soft tissue inadequacy around number 6. That's pretty easy to fix. That would be 1-3 for the Europeans, okay? But in a case like this, we don't necessarily need to replace any soft tissue. We could clean it up. We could do some grafting. We could bring the margins down of this free gingival margin down. Not too tough in a case like this. So the first thing you're going to do is you're going to look at the transition line. The second thing you're going to do is you're going to say, am I going to do a composite defect case or is it a no defect case? Okay, so in the composite defect case, this was his final PMMA, okay? Now, the interesting thing about this person is he will only pay cash, and so he wanted to start with his top because he's smiling, and then soon we're going to get to his bottom. But what we did was we gave him back a composite defect that looked very, very natural compared to his gum tissue. So when this guy smiled, he couldn't see it. So again, transition line, which I'm going to show you a couple more slides in a minute, and then is it composite defect or not? So you take something like this, that other case that I just showed you a minute ago, and you can create with the right attention to tissue, and if you can't do it, that's okay. A lot of people can. With the attention to tissue and detail, if you could bring all the margins down to, you know, the teeth like this, then you can easily hide something. And I'll show you that case in a minute. Okay, here are the 3 images that you need to take to assess this. The first one's going to be at rest. I'm sorry for the blurry images, okay? The first one's going to be at rest. Just tell them to barely touch their lips together and breathe. Because some people don't touch their lips. Some people will leave an opening. Okay, tighter lip, that smile line will tend to be a little bit low. Okay, then the next thing you're going to do is say, Lisa, can you give me a smile, like a social smile, like if you were out at a club or a restaurant or something, and you were just introducing yourself to someone. That would be the middle one. And then Lisa, I need you to give me a really, really, really exaggerated smile. And you're going to catch that one. Now, the first thing that I would do is I would work off the one all the way to the right. And I'm going to make sure that I measure the difference between her lower lip line in an exaggerated smile and the bottom of the gum tissue. And I'm going to write, I can see 3.5 millimeters of gum tissue. So that means from the new CEJ, I am going up at least 4.5 to 5 millimeters, because this person has good teeth. They're all natural teeth. But in the case of someone like, you know, the last case I showed you, Andre, he is going to learn how to smile. So he's going to go from someone on the left that you see more towards the center, and then inevitably going to be on the right. So we really need to protect ourselves against that. So here's that case that I was just mentioning. That's a no composite defect case. It looks beautiful, right? Okay, so we were very happy with this case. Everything came out really nice. But the reason, and I posted this on Instagram last week, this is really important. If you look at the purplish pink arrows, it says from the incisal edge to that black line, that's 15 millimeters, okay? Now I'm gonna go over some measurements for materials in a second here, but 15 is an average number, okay? 14 you can use for zirconia, but even if you drop that line 1 millimeter, imagine if I went to a zirconia bridge or a hybrid on this person, and I did a little bit of bone reduction, and I created 14 millimeters of space, okay? That transition line would be located below this black line. And this is somewhat of a forced, relaxed smile. So this person isn't even smiling really big. So what you would be looking at in this case, if I had chosen to do this, is you would see the transition line from the fake stuff to the real stuff, and it would look really bad. So let's look at this. So here's the free gingival margin, okay? This is typically where the bony housing was. We placed our implants obviously into the bony housing, and we were able to preserve everything and go with a white tooth bridge. Now, if I were to go back and show you some of those composite defects, here's the takeaway. When you look at a case and you see recession of gum, bone, tissue, whatever, you have to look at it like something needs to replace that. If I replace it with all white, I mean, you can go online type in full arch ceramic bridge, and you're going to see cases with patients that have 15 mm front teeth. I'm not going to comment any more than that because I wasn't there and I don't know why it turned out that way or what, what the restrictions were, et cetera. But you have to plan for this because this could be a disaster. Okay, so now let's start walking through some surgery. Okay, so I met this gal, Deanna. She actually came to see me from California, and this was her CEJ to incisal edge. Okay, 12 mm. And this is how she smiled. Okay, the black lines are what I saw when she smiled. Okay, she had a very, very gummy smile. So what is the take home here? The take home here is if you have a gummy smile patient, this is going to be very challenging, because if you decide how to hide that transition line under the lip, you now have to make sure that you have enough bony height to place your implants. Okay, so this is all incisal edge prosthetically driven, okay, or indicated, I should say. Okay, so right now, if I went from her incisal edge to her CEJ and I have 12 mm, theoretically, I only need 2 more millimeters for a zirconia bridge, okay? So when she smiled, I saw what you see as the black lines. I saw 3/4 of her bottom teeth, I saw all of her top teeth, and a lot of tissue. I mean, look at the bicuspids. There's 8 mm of tissue there. So if I would have, placed the transition line on Deanna at this black line, every single time she'd smile, we would see that transition. So this was immediately post-surgery. We cleaned up her bite a little bit. We did upper and lower at the same time. And this was denture conversions, top and bottom. We'll show you some stuff with PMMAs in a little while. I'm just checking time, so we're 1 hour in. Okay. So this was on the spot. This was 2 full arch stackable guided surgeries, and it came out beautiful. And the transition line, we lifted everything up 2 mm, and I also lifted up the transition line another 4 mm. So this is immediately after surgery. And she looked really pretty. She looks a little dazed here because I just woke her up out of IV sedation. But this is quite a service, actually. She was really, really happy. And I will tell you, I'll go as far as saying that this lady had a very unbecoming smile. When I met her and she smiled, I mean, she showed 8 to 10 mm of gum tissue in the repose or in the relaxed smile that you're looking at right now. So in an exaggerated smile, if you look at the teeth, I still have about 20% of tooth under the lip, and then I have another 5 mm of acrylic. Okay, so what I'm saying now is the hardest part of all of this. You have to work on that. Smile line, transition line, material. Okay, so there we are. All right. Now, I inherited this case, okay? This is a disaster. So somebody planned this case, got the video correct, went into an edge-to-edge because this patient was a class 3, and apparently the doctor offered the patient an edge-to-edge or surgery. So what they did was they did a very, very nice job here if you cover the gum tissue, right? So if the lady barely smiled and gave you a grin, it was actually really, really nice from where she came from. But this lady came to me and said that a couple of the implant sites were hurting and that she kept getting food stuck, and how could she clean this thing because it's, hugging up against the tissue. And I'm looking at it, and this is a big deal, you guys, because as you could see, this is a temporary, I believe, I can't remember, but when I met her, this is what I saw. And when you look at that number 7, that's an issue because I can't grow any bone beyond the platform of the implant, which means it's going to be really, really hard to have any type of soft tissue because the blood supply is gone. So what do you do with a case like this? Honestly, if it wasn't going to be a lawsuit for the other person and this patient wanted it done, quote unquote, correctly, I would take everything out and start all over again. I know that sounds brutal, but that's the Scantron answer, guys, because this is a surgical success, but it's a prosthetic failure. big time. And if somebody comes to you and they're willing to drop $25,000, they don't care about the surgical part. They don't care if your implants are angled, if they're not angled, what size they are. What they're coming to you for is not this, okay? So I know I've harped on transition line, guys, but it's a big deal. Okay, so I'm gonna run through this real quick. There's 2 requirements of the surgery, then we're gonna get into a surgery, okay? Number 1, we need a DICOM file, which is your CBCT file. Number 2, you have to have an accurate, planned prosthetic outcome of the teeth before you start. Now you're gonna have to figure out the transition line, the smile line, and all that. That's in photos, and that's you with the patient, okay? All right. And together, that's the dual scan protocol. So there are 2 different ways that we do this, okay? I'm gonna fly through this. So for a partially edentulous patient, which is, let's just say 3 or 4 or 5 teeth, you have a patient scan, okay? And then you have a dentition scan. So there's the patient gets in the CBCT, and then you get an MPR multiplanar view, and then you also get a volumetric view, okay? And this is a file, this is a DICOM file that is going to help serve when you go to design this case 3-dimensionally. Now the second part, the second scan is gonna be the scan of the dentition, and there's a couple ways that you could do it. You could pour up a model, you could put it in the CT machine, and you could scan it. I know a lot of you, including me, have intraoral scanners. So take a scan of your patient, very, very easy to do. Send it off to the lab or whoever's making your guide, etc. Now this is gonna be referred to as the STL file, stereolithography file. And this is going to be essentially what your guide is gonna be made of. So when you take an intraoral impression of your patient, like you see here, the guide is actually made on that. The CBCT is just really, really used to superimpose on this STL file and to also safely place your implants. Okay, and then the last way to do it, which is how I personally do it, because I do a lot of this, and 3D Diagnostics does this, is you actually can send an impression to 3D Diagnostics, and they will scan it in an optical scanner, high-powered lab scanner, and they'll get an inverse of the model, or in some cases they'll pour it up. And I do want to mention something that I didn't at the very beginning, and that is, I'm not taking any money for this webinar. I'm not vested in 3D Diagnostics or anything else that I talk about. I'm not an educator or a speaker that gets rewarded on things that you buy. So I just want to make that very clear. I'm very passionate about who I use and who I work with because that is part of my results. So that being said, you can actually just take a good PBS impression and just drop it in the mail, 2-day it, overnight it to 3D Diagnostics, and they'll take it over from there. Okay, and then what we do is we take those 2 things together, we do what's called a data merge. The purple would be the STL file of the teeth, the black and white would be the CBCT, and then what we're gonna do is we're gonna dump it into a third-party software. The one that I use, which is the most widely used software, is Co-Diagnostics, and then you could virtually place pretty little fuchsia color implants, length, platform width, angulation, all that stuff, okay? All right, now, what we're more interested in is how do we do this for fully edentulous. Now there's several ways to do this, and we are definitely getting into, you know, full arch scanning, et cetera, et cetera. This is just my opinion, being an educator. I wait until a couple generations have proven themselves. So I want to tell you that the way that I do it is not the only way to do it, but it works for me, and I want to make sure that I can get sound muscle memory replicated results over and over and over again. Okay, but full arch scanning is here. It's around the corner. The new technology's coming, so keep your eyes out for that. Okay, so patient comes in and wearing this denture. Okay, now the denture isn't great, okay? We can make some changes, but I asked her, you know, how is the denture? And she said, well, other than using a bunch of glue, you know, it's okay. I said, can you eat with it? She said, yeah. I said, is there anything that you want to change about it? And sometimes they'll say little things like, well, I don't like the canine, or I'd like them to be lighter. Okay, that's fine. My point that I'm getting at is if it's relatively close, okay, where you're not going to have to open the VDO 4 millimeters because it's ground down and broken, what we're going to do is we're going to save everybody costs, and we're going to use her denture. And here's what we're going to do. Again, remember, light bulb, create the prosthetic plan first. Okay, So what we're going to do with her denture is we're going to put on some glass beads. Now, these beads are referred to as fiducial markers. And fiducial markers have been used in TV, film, movies, sports, entertainment. And what it is if you've heard the green room, fiducial markers are used on things or people or animals that give you a fixed point of reference. So in other words, if you take a fiducial marker and you put it on the human actors, like you see in this image, on their feet, on their shoulders, on their head, etc., and then you do the same thing to an animated object like the ninja guys, you can actually combine them and make the turtles look like they're the human beings, the facial expressions and everything. And I know that a lot of you saw Avatar, Bug's Life, all of these movies were Pixar movies. They use this fiducial animation where they could superimpose and make ants look like they're humans. Okay, so how do we do that in dental? Well, what we've done is we've come a long way. When I first started doing full arch stuff 15 years ago, I would make a barium sulfate duplicate denture. And that's fine, 50 or 60 bucks in the lab, or you can make it yourself, whatever, but then you just throw it away. Okay, and the barium sulfate denture was a clear radio opaque denture that you can actually fit to the jaw and you could see everything together. Then we went to cutting holes in the denture with an 8mm round burr, or number 8 round burr, and we would stick gutta percha and use those as markers. Well, all that has gone away for the most part, and now we're on to these little glass beads. These are Suremark glass beads. They are 1mm. They come in different sizes for different applications. I highly recommend the 1mm. And 3D Diagnostics, they do sell these. I think they're 75 cents or 80 cents a piece. I'm not sure, but you can go to their website. So what we're going to do is we are going to use fiducial markers like they did in ants, because what we have to do is we have to take the fiducial markers and put them on teeth when the teeth aren't connected to the patient's head. Okay, so the first thing that we're going to do, the very first thing that we're going to do is we are going to take the denture or dentures, and we are going to put 3 beads on the outside, staggered, and 3 beads on the inside, meaning palatal-facial, buccal-lingual, and we're going to scan the prostheses, okay? And the reason that I want you to do this first is because when you put these prostheses in the patient's mouth, which is going to be the second scan, sometimes the moisture in the saliva makes these beads move and you won't know the difference. So the first thing that we're going to do, if you're doing upper and lower, this would be 3 scans, okay? Meaning you do a scan by itself of the maxilla with beads and a scan of the mandible with beads. Now, the important thing that you do here is you have to make sure that you set the denture on something that is radiolucent. And the reason for that is because the incisal edges have to be depicted perfectly. And if you set it on something that's radio opaque, like that chin rest or something like that, the incisal edges will bleed into the opaque rest. So we want to set it on something. I've used glove boxes before. This works really, really well, this pack of cotton rolls. Set it on as you see and scan, and then you do the bottom as well, okay? All right, and so what's gonna happen is we're gonna have this denture with these beads. And as you go through different views, these beads will, come in and out depending on what view you're looking at. So what we have here is we have the Ninja Turtle. So we have the Ninja Turtle, but the Ninja Turtle can't do anything without the human, right? So this is the Ninja Turtle part, or the avatar part. So now let's add the human, okay? So as you could see here, this was a plan that I did with 6 implants on the top. And in blue, the circles are the beads. Okay, so what I've done is I've scanned the scanned the denture, and now the second one is going to be the patient wearing the prostheses. So now what we could do is we can join them, much like what I said about ants. And there's a reason. Because we want to make sure that when we line everything up, that we can decipher where the implant should go based on teeth that really don't belong to their head. Okay, now what you're going to see here is the bone. This is the cross-section outline of the denture tooth. And this is my proposed implant. Now, the great thing about that is I could design it with height, angulation, et cetera, based on the cingulum. So I don't have any holes in any of the facial aspects of my teeth, okay? I can bring it back and position it to be right in the cingulum where it should be. Now, one of the things I want to point out is if you look at all three images, you look at the bone and then everything else is radiolucent. If you have any dark space between the bone and a radiolucent, that means it's air. And we need to make sure that we don't have air in our denture. And I'm going to show you how to handle that. From that, we're going to merge everything together and we are going to create a surgical plan. Okay? We're going to create a surgical plan. Now, here's the key. It is another light bulb moment. It is very important that you do a reline on the denture. Okay? My recommendation, strong recommendation, is that it's a soft reline. I use a material called mucoprin. And the reason I recommend that you use a soft reline is, especially if they've had the denture for a while, or if they haven't, if you have a hard reline done, they might be initially uncomfortable with it and they might bite awkwardly. This has to fit the intaglio surface really tight. When you look at this denture, I want you to look at it like that is your guide. That is what's going to sit on your tissue. And if you have air, it's going to rock. So I use the mucoprin product. These just came out of a 120-degree plaster bowl bath, which cures the material, and then we'll go ahead and cut it off. But you want a really good intimate seal between the denture and the intaglio surface of the patient. Now, this denture you're looking at is the denture that the gal came in with. So I don't care that the denture is old. What is most important is the VDO correct, and do we have a good representation of the intaglio surface on the inside of the denture? So far everything's good. Now, how do you know if you don't? Well, it's going to look something like this. If you're familiar with CBCT, what you want to do is you want to be in the frontal view, and you want to go in and out. So you want to go from the nose to the neck, back and forth this way. And what you're going to see is you're going to see either a seal or you're going to see air. Okay? This is not good. On the patient's right side, your left side, it literally looks like it's hitting the bone. On the right side, on your right side, patient's left side, it's wide open. Okay? Again, the surgical guide is going to mimic the denture. Okay, so here's what you can do to help. Okay, if all else fails, you can go to the 3D Diagnostics website. They have a great library on how to scan your patient for this stuff. But here's what I do. I use 6 cotton rolls on the top. 2 cotton rolls are going to be under the vestibule. I think I have this backwards. Yeah, I have this backwards. I apologize. We're going to switch maxilla and mandible. I use 4 on the top, 2 in the vestibule. And then it pushes the soft tissue away from the flange of the denture. Then when they walk into the CBCT, we put 1 cotton roll from the first bicuspid to the first molar and ask them just to gently, passively put pressure down into the cotton to push it up. On the bottom, and I apologize, these are backwards. On the bottom, I use 6. I'll use 2 in the vestibule, but I'll also use 2 underneath the tongue, and then I'll have them bite on the sides, first bicuspid to first molar, and walk into the CBCT. You do not want them biting on the bite stick because they'll tip it, okay? And then it will not be accurate. Now, the advantage to that is the more that you can move the soft tissue away from the appliance, the better and more clean your merge is gonna be, and that's everything. Okay, so let's go for it. Let's do it. Okay. The case I'm going to show you, now that we're in April, I'm allowed to do this, but last month I couldn't. This case that I'm going to show you, I was featured in Dentistry Today in March last month. I needed the issue to come out and pass before I could share this with you. But if you want to go back and look at it, get your hands on a Dentistry Today magazine. I'm right there. I'm on the front and somewhere in the middle for last month. And this case is in there. Okay, so here's a question for you. When you look at this image, when you look at this slide, what do you see that is consistent? What do you guys see if you were going to be quick to figure out a puzzle? What do you see? Fundamentals of wireless communication, fundamentals of calculus, fundamentals of piano, fundamentals of accounting, fundamentals of management. Guys, let me tell you this. Fundamentals are key in everything that you're going to do surgically. This is not about ego. It's not about money. It's not about notoriety. It's not about any of that. You're an artist. Yes. And I'm an artist. And our job is to stay true to fundamentals, let all the other stuff go, and be fundamentally sound. And if you're not, that's up to you. Then work on it. I remember my first case. I remember my second case and my fifth case and my 10th case. And I'm always going to remain humble because I learn every time I do this. And I've had challenges, teeth not going in correctly, you know, impressions coming out poorly, maybe the bridge not seating all the way down. And all of these things keep you humble. But stay true to the fundamentals. Don't look for shortcuts and learn, okay? Learn. Fundamentals are key. Okay, so we're going to be done right at 3:30, so that worked out well. Ish. Okay, so here is a patient that came into my office. This is the gal that is in dentistry today. And I inherited her, because of an kind of an unconventional way, let's say. She went and she had an upper hybrid done, and she had problems with the upper hybrid, and so she came in to see me, and she had questions about the hybrid that was done, and she also wanted to do some work on her lower arch. So if you look here, as you get used to looking at x-rays, I have some suspicion about the size and shape of the bar. Okay, so here is an occlusal view of her, and here is a frontal view or a facial view, okay? So there's a lot of things to think about. Now, we know inherently women show far less lower teeth than men. So, so that helped us here. But nevertheless, I had to do a lot of things here. This wasn't just a, you know, build up the case with composite and, you know, and kind of go for it. I had to plan ahead. So here's Tanisha, and this was her incisal edge, existing plane of occlusion in the green line, okay? Now, what we did was we did a virtual wax up based on evaluating her smile of where we wanted the teeth to be. So we wanted to add to what she has lost and try to give her back what nature or her bite took away. So if someone says to me, you know, doc, what are my teeth gonna look like? I always answer them the same way. I'm gonna say, you know what? I want to make your teeth look like they were yours this whole time. You just took really good care of them. That's what our goal is. So now this yellow line is the proposed plan of occlusion, okay? Now this is part two. The first part is incisal, is smile line, transition line, all of that stuff, okay? Take your photos. This part two is now executing it surgically. All right, so everything is based on that flashing yellow line. If the incisal edges I want there, then everything works downward. How do we do this? Okay, so if I like the position of the edges of the teeth there, the next thing that comes into play is, what am I using for material? Okay, what am I using for material? Because that's going to dictate the implant positions, right guys? So if I like the teeth there, and those teeth aren't moving, okay? If I'm doing a bridge that requires 16 millimeters of space for thickness and strength, then I've got to push those implants down 16 millimeters from the incisal edge. So the incisal edge determines all of this. All right. Now, let's go over numbers, okay? This is something that is agreed upon. Dr. Hess at Decisions in Dentistry. Why the space? Well, lingual tooth height, few millimeters, acrylic height, and this can vary depending on the lab, 2 millimeters, metal framework, 8 millimeters, space for cleaning, 2 millimeters underneath, and tissue depth. So the depth from the platform to the top of the tissue, average of 3 millimeters, for a total of 18 millimeters. Now, I'm not gonna argue these numbers because they'll wax and wane. I will tell you this, okay? I was planning on using a zirconia bridge on this gal, and it cleared her smile line. There was no issue with the transition line. So I needed 14 millimeters, okay, for a zirconia. So let's look here. So once you get the incisal edges where you want them, and you decide what material that you want, That is going to dictate the space that you need to create, and then the implants will go there. Okay, so let's look at the numbers. So this gal was going to get a zirconia bridge such as this was a Brent's case that I showed you earlier. 14 millimeters from the platform of the implant to the incisal edge of the teeth is what you need for zirconia, because this doesn't have a bar in it. If you are doing a titanium bar with an acrylic wrap, you need 16. The reason I mentioned 18 a few minutes ago is because that graft and study was done on gold titanium bar, which is a lot more malleable and not quite as hard as titanium. So it needed to be thicker. So today what we're generally doing is, and I know that a lot of people are looking at pectin and all, all types of other materials, but 14 will get you home free with their zirconia bridge. And if you can have up to 16, it leaves your options wide open. Okay, now look at this. So this is how I met her, okay? This hybrid that she had done, titanium bar, acrylic wrap, is 10 months old, okay? Everything about this was bad. Her midline was off, she had a cant. This thing was, if you look here, 10 millimeters thick. And it even dropped down where the crack is. It went to almost 8. She paid $23,500 and she was told that it's porcelain. Okay, guys, I know that you've heard this before. I know that you know someone that has said this before, hopefully not you, but here's the thing. This is a big deal. Patients save their entire lifetime. Then they finally get in the chair to no sooner have you do full-blown orthodontic or surgery on them. You got to deliver. So I would recommend that you talk about materials, have the materials there, talk about the maintenance of the materials, etc. And you can hit me up on Instagram if you have more questions. I just needed to kind of get through everything and truncate it. But this is a lot of money. This is a lot of money. And to be told it's porcelain, we are not using porcelain, okay? If you're using, something like an Emax material, and you want to say it's porcelain, that's fine. But I mean, if you're using zirconia, say it's zirconia. If you're using acrylic, say it's acrylic, okay? And by the way, an acrylic wrap such as this, when done correctly, is a beautiful, beautiful option. Okay, so let's look at the surgery. Let's do our surgery now. So the first thing that we're going to do to start the surgery is, oh, by the way, so when she came in and it was cracked, I told her that the only way that I would do the bottom is if I got to do the top again, because everything was off on the top. And I explained to her, and this is a great learn for you guys. I explained to her that if I were to do just the bottom, the top dictates what I do on the bottom. So if he maybe made it too thin, then are my lower teeth going to look too tall? If I want to do zirconia, am I going to pound those acrylic teeth even more? So they agreed to eventually have me redo everything, but you got to be really careful about what you inherit, because now all my work kind of is opposing that work that was, in my opinion, less than adequate. And I even told her, if I do this, there's a high probability that I'm going to accelerate the breakage of the top one with her zirconia bridge. And they were in a dilemma. The dentist was in a dilemma. So I just decided to be a nice guy and help everybody. So I worked it out with the dentist where I told him the space I needed, and I sent him a bite room, and I just helped him work it all up. And I think, and he redid it, and the result is B plus. You'll see in a minute. Okay, so this is called the pin positioning guide. All right, guys, the pin positioning guide sits on either the teeth, okay, or if they don't have teeth, it's going to sit on the tissue. This is really important, really, really important. The accuracy of your impressions, your scans, etc. This is huge. So what's going to happen is we are going to put this pin positioning guide down, and then we're going to drill with the provided anchor pin drill, 15 millimeters, 1.5 millimeters in diameter, 17 millimeters to depth. And these are all planned, by the way. And then we're going to put the pins in, push the pins in. Now, anytime you're securing a guide like this, Somebody needs to mute. Yeah. Sorry? Okay, so anytime that you're positioning these guides, you guys, this is huge. This step sets up the entire surgery, okay? So passive pressure on both sides by you and or your team, gently just pushing it down to make sure it's secure. It has windows in it, so you can see the teeth. Same thing with the tissue, gentle, slight blanch, okay? But it has to be pushed down together and not forced down. Now, I don't know if it's hysterical. And that's basically what's going to happen to you if you forget this step. It's game over, okay? All right. Now, the next thing that I'm going to do is I'm going to atraumatically take out these teeth. And the reason for that is the obvious, but I'm going to use what's called a cube, and I'll go down. It's the cube made by Acteon, and if you look at the roots, they look like they're almost bathed. They're not. They came out that way. It's a piezo unit that I go down and separate the PDL and roll these teeth out. I take a lot of time with my extractions. A couple of things. Number one, when you see teeth ground down like this, guys, there's a high probability of ankylosis, because if you stress out bone, it's going to hug these teeth. And the problem with that is you have a very thin facial plate. And the facial plate is what's going to hold the guide. So don't look at it like rip the teeth out because we're cutting everything away. This is create muscle memory and do the same thing every time and do it pretty. Okay, so now what you see here is the teeth out on your left, and then on your right and your left, you see the holes, okay? The arrows, the white arrows before reflection and after reflection. Now, there's a lot of things that can quote unquote get you. This is definitely one. You have to learn how to do fairly aggressive flaps, okay? As you see on your right. You, in some cases, have to expose the mental foramen. You've got to be very, very careful on the lingual border, the sublingual artery. There's the lingual artery in the back of the mouth. So be really cautious about this and learn and learn and learn where this stuff is. What I'll do is I'll do something like either a mid-crestal, it doesn't matter because you're reducing bone, you're gonna have excess tissue anyway, or I'll go slightly lingual. And once I get to where the first molar is, I'm gonna tail out facial. I'm not going anything past the first molar to the lingual. And then what I'll do is I'll just gently peel everything away. And as you can see, nothing is gouged. There's not a ton of bleeding. It's because I kind of took it like an orange peel and peeled it off. Whenever you're working on a case like this, whether it's the palate or the lower, the floor of the mouth, take a suture and tie it as you see here, the black thread, pull it together. Because once you go in with the next guide, it's very hard to control if that tissue is just moving around. So gentle, really gentle, like eloquent, exquisite flaps, you guys. It will really help. Okay, now, what we're gonna do now is we are gonna go ahead and place what's called our bone guide. Okay, and our bone guide is no different. UGPs have done it before with a reduction guide. Okay, you get a reduction guide from the lab and you just cleave off everything above the prep and you suture crown. And I know the surgeons that are listening, they know how this is done. So here's the key. You have to have passive fit of this bone guide, the reduction guide. Because if it's wobbling around on tissue, everything's gonna fall to error. Everything's gonna fall to error because everything sits on here. So pin positioning guide for the holes, nice clean dissection of all tissue, keeping in mind all the anatomical landmarks. Seat this thing down passively, and now what happens is these 4 pins should passively go right to where you drilled the first pin positioning guide. Okay, so now what you're gonna do, just like the reduction guide, is you're going to smooth it out. Now, if you notice my hands, 2 hands, 5 fingers fulcruming, I work really, really passively. And I like using the word pretty because I think that's exactly what I'm trying to do. Just really pretty. I'm not banging on her jaw. I'm just painting, okay? In fact, the less that you push down with the burr, you have your sterile water going. The less that you push, actually, the easier it is to cut bone. So now what we have is we have an ideally reduced jaw. Now, you want to be really conscientious of the horizontal plane on this reduction guide, because if you go crazy and you really take a lot of bone away, then when your implants go in, you're going to have troughing around your implants, because the implants were designed to be at the level of that purple bone reduction guide. So less is not, more is not better. You want to look at it from the side. What I'll do is I'll take my probe and I'll rub my probe back and forth and see if I have any bumps. And I just want to go smooth. Okay, so now what we're going to do is we're now going to put on our implant guide, and that snaps directly onto the bone guide, as you can see here. Now, this black line, I'm going to go back again in case you didn't see it. Watch the front, canine to canine. That black line, there should be no gap anywhere around the whole aspect of this implant guide. If there's a gap, that means it's rocking on a peak of bone. Okay, and figure out by tipping it where you think that lever is and go and smooth it. Okay, if you take too much away from one side and you were wrong and you needed to go to the other side, we can always graft around implants. That's not a problem. Okay, now that's the implant guide. Now there's a vertical stop and a horizontal stop, and I don't want to get too much into that because I play Strawman. I'm a Strawman guy, and this is going to change for all of your systems, so I don't want to get too much into that. But essentially, the driver has a line on it, and I'm supposed to line up that line with that green line that's made for me from 3DDX. So there's a horizontal line that drops down to the sleeve, and then there's a vertical line that lines up with that green line, and then I know my implants are positioned correctly. Okay, so I want to talk about 4, 6, 5, etc. just for a second here, and then we're swinging down to the end, and thank you guys so much. Okay, so important that you understand that, I'm going to move something here. I can't. Okay. The blue circles, the anterior implants, they receive what's called a tensile force. So when you chew in the back, they're getting pulled in the front. This can be a dangerous force. Okay. So what we want to do is we want to equal those out with the appropriate occlusion. Next, I'm going to skip to zone 3. Zone 3, the pink dots are compressive forces. So they handle all the biting and chewing. And it's very important when we talk about Newton centimeters, there's all kinds of ideas of how much strength we need. Some people say 120 for a full arch. There's all kinds of stuff. I could just tell you this. 130 is an okay number. My recommendation to you is that you try to achieve 35 plus. 35 to 40 on all of them. If you're under a couple, that's fine. But you definitely want to under prep your posterior ones, because your posterior implants are going to take the most force on the distal lingual aspect. So you want to make sure that whether it's 3 and 14 or 4 and 13 or even on the lower, you want to make sure that you really under prep those back ones, because they are taking the compressive forces. And this is where we're going to get into, is all on 4 better or not as good as all on 6? Well, here's the study. The study says that the yellow ones placed in zone 2, okay, handle all the lateral forces. So we're gonna do what's called protective occlusion. I have 1 dot on every tooth, so to speak, and missing in all of the protrusive movements. But we now have what's described as, not now, but we describe it as zone 1, zone 2, and zone 3. It's imperative that we get 2 implants in zone 1 and imperative that we get 2 in zone 3 for those forces. And that's your typical all on 4. However, if we can get 2 more, that will help obviously with more titanium, but also help with lateral forces. If you lose an implant, for instance, let's say you were to lose one of the yellow dots, you could still load the whole thing. Theoretically, all you need is 2 red and 2 blue positioned correctly, like you see here. So I am a guy that does 6 on the top and 5 on the bottom on my hybrid cases. Typically on crown and bridge cases, like you saw earlier, I'll do 8 implants. Okay, all right. So here's Bobby again, and I'm bringing it up because why are we tipping implants? Why do we tipping implants? Well, we tip implants to increase what's called the AP spread, and for those of you who already know this, I apologize. And to also stay away from the anatomy. So if you look at the right image, right X-ray, and you look at the bottom arch, the posterior implants are tipped back. Why? It's to put the platforms in the position of the first bicuspid or maybe second bicuspid. This is a flat image, so it's pushed it together. But why do we do that? Because the old AP spread, and it's not old actually, this was when Brandmark came out, he talked about a cantilever, okay? So the green line would represent your anterior implant to implant. Now, some people measure it from the center, some people measure it from the facial aspect. I'm not that anal, just whatever. I go center to center. So center to center of your top two implants. So if your implants are staggered, then you're gonna draw a staggered line. Then your back two implants, as you see here with the pink line, that would be your posterior, okay? The line in the middle, the yellow line, the 9mm line, is anterior posterior spread. Now, the cantilever, a conservative cantilever, says you take the anterior posterior spread and you multiply that by 1.5, in this case 13.5, and that's how far you can hang off from the center of the most posterior implant. So if your implants are not equal on both sides, then you can't make a bridge that has first and second molars because you're going to rip one out. You're going to literally rip out one side of the jaw. So I want to encourage you into some new thinking. My recommendation is that as you approach this, that you consider a 10-tooth bridge, okay? Canine to canine, one bicuspid and one molar. And when you tip these implants, okay, to increase the AP spread, and you get an angulated abutment that corrects it, you can avoid a cantilever, okay? Cantilevers work, but they're not, in my opinion, optimal, okay? So here's just a couple more views of that. You know, depending on where your implants are positioned, you can either have a long cantilever or not a long cantilever, okay. All right, so this is how I now do my cases. So I'm gonna bring the back forward and I restore all of my cases in first molar occlusion. If I feel like I can get the implants back or tip them back, I'll give them 2 bicuspids. If I feel that the sinuses or the nerve or something is prohibiting me from going back, then I'll give them 1 bicuspid. And I now do not do anything more than a half a tooth cantilever. Okay, so let's look at how this works. So we have angled implants, okay? And the way that this works is now we have screw retained abutments that correct angulations. Straumann is 17 or 30 degrees. So as you're planning these implants virtually, you could see the degree of angulation that the implants are. So if you tip it back and it looks great under the molar of the tooth and it's 17 degrees, then go with a 17-degree abutment. Now, what you see here are 2 abutments and 4 screws, okay? Let me go back. Okay. So the compensated abutment is either 17 or 30 degrees, or they're 0, like in the front. The screw going down through the abutment into the implant is the abutment screw. Typically, that's a 35 Newton-centimeter torque, okay? But there's an asterisk there. If you only get 25 on the implant, you can't torque the abutment at 35 because then you'll spin the implant. So tight finger pressure at time of surgery is best. If you have torqued out your implants to 35, 40, then go ahead. I won't put them in more than 25 initially. I'll just, at the patient's follow-up appointment, I'll tighten them when it comes time to get the definitive PMMA, or the next step to the PMMA. The screw going down, that's the prosthetic screw. That's gonna compensate for your angulation, okay? So if we look here, this is Bobby's case. Here's her tissue. So what we did was we increased the positioning of the platform with compensated abutments, and we were able to get the downright abutment in the position of the molar without involving the sinuses, okay? So we tipped them 17 on one side, I think, and 30 on the other side, or I can't really remember. And now we have your compensated abutments. Okay, now, so tipping implants. So now I place my implants, the implants go in. Now the next thing that's gonna happen is you're gonna put on what's called an abutment guide. And the reason that this is really important is because for the implants that were tipped, you have to put the abutments in the right spot. If they don't have a green line, like you're looking at here on your lower left, then that means they're 0 degree, just put them in. Any position, just tighten them in. If they do have a green line, like the posterior ones, that means that I've tipped them. This is your prosthetic screw, or what will be your prosthetic screw. That is your abutment handle carrier. That's what you bring it to the mouth in. This is going to be your abutment screw, or this is the driver putting it in, but the black will be your prosthetic screw and the white will be your abutment screw. Anything, if you want to remember it really easy, anything that is tightening to the implant, you torque it. Anything that is tightening teeth down, you hand tighten, okay? So here you can see the carrier, and you can see that it's 17 degrees. So the carriers, so the implant, the driver is 17 degrees back. The carrier is straight up and down. So you could see the driver is the position and angulation of my implant, which was 17. And the carrier is the compensation of the SRA abutment, taking me from 17 to 0. Okay? So we put on the abutment guide, and there are our abutments. Now, if you look in the blue circles, those screw holes are pointing to that green line. So with Straumann and these types of abutments, and typically everybody, you can either put it in one of 3 or maybe one of 4 positions. So those green lines have to be lined up, in this case with Straumann, with the screw holes. And then the top is the prosthetic screw finger tightened so I can have a good path of insertion. Okay, so here are the abutments now. I want you to notice something here, okay? So what's gonna happen now is, now what we're gonna do is we're gonna go to the teeth. But look at how closely we were thousandths of a millimeter off as we superimpose these implants. Planned angulation. So when you look at the implant in the number 28 position, it's tip lingual. Look at the one on the virtual wax up, same thing, tip lingual. Look at the yellow circle. That's the emergence profile of the implant, tip lingual. Ideal. Why? Because the bone dictated that. And that's an easy correction with prosthetics. So if you stay to the fundamentals and you follow all these steps, it's maddening. It's awesome. Okay, so what's going to happen now? So we have the pin positioning guide still on, okay? The implant and abutment guide have come off. So after you put the pin positioning guide in, the bone reduction guide goes on, then it comes off. Then the implant guide goes on, you place your implants, it comes off. Then your abutment guide goes on, you place your implant abutments, that comes off. So now what we have is we still have the pin positioning guide in place, and we're now going to put temporary cylinders on, and we're going to tighten them, okay? Finger tighten these. Anything going into these abutments is finger tighten, okay? Then we're going to stuff the top with, you can use impression material or plumber's tape, okay? Now what we're gonna do is we're gonna take the PMMA and have the patient bite into the bite that was provided by 3DDX of the top teeth and the new bottom wax up, or the virtual printed model, okay? Now, 1, fill the cylinders, because you don't wanna get this thing stuck. It'll be a very bad day. 2, you wanna make sure the cylinders are down and take x-rays. This happened to me. I got 5 of 6 down. 1 had a ledge, it was tight. I went to seat the teeth, and the final one wouldn't screen because it wasn't all the way down. So what I had to do was cut a hole and re-pick up that one. Not the end of the world, but make sure that they're down. And don't be too impatient with the occlusion. Just work at it. It takes a little time, okay? Now what we're gonna do is, you can see in the far left, there's those little holes. This tip, this pickup material tip will fit in those holes. You squeeze it, then you come back on the inside. And all you wanna do, you don't wanna overload it. You just wanna put enough in there where you can light cure it and it will grab the cylinder. So that, the next thing we're gonna do is take out the silicone tape in this case and unscrew the whole thing. And it comes out like that. In the meantime, what we're gonna do is, while we're fixing that in the lab, this is a funny image right there where the mirror is positioned, but there are 6 protective caps put on there. And what you want to do is put the protective caps on and suture all the tissue together now. And then we went ahead and finished the prosthesis in the lab. We polished it up, cleaned it up, etc. Okay? And then this is her final PMMA delivered. We added some color to it, and it was darn close. Now, her lower PMMA midline actually matched with her interpupillary line and her midline of her nose. So I'm building her up again. Now, this is when she comes back. This is at 4 months. Tissues look great, bone looks great, everything looks good. And what we're gonna do is this is a conventional impression procedure. You could see the 2 of the implants, just a quick x-ray, it doesn't have to be perfect, but what I'm looking for obviously is bone heights around implants, which look gorgeous. And I also wanna make sure that my impression copings are down. And then we take one on the other side and I could see what I need to see. So all 5 implants have done really nicely at the level of the bone, and we're ready for our impression. Okay, so what we're gonna do is we're going to lute this together and create an in-house jig. This is Prima Plus, I think, from Ultradent. So we'll put floss from coping to coping, and then we'll light cure this. Then what I do is I section it to allow for shrinkage and expansion, and then I'll relute it, and then we will pick everything up. And here is the PMMA that day. Okay, and PMMA materials, I'm sure you guys know, come in a plethora of colors and shades, and then the pink is added, or in some cases, it comes in a pink puck. Okay, so here is Miss Tanisha. She looks beautiful. The restorative doctor attempted to redo the top, and I'm still not happy with it. So her midline on the lower is good. So this is the final PMMA. This is what we'll do in round 2. She'll wear this PMMA, and the tissue will heal. You know, has healed. So we want to make sure there's no food trap, etc. And let's go back. And that's it. So this is her second PMMA. This is the one 4 months down the road or 5 months down the road after all the tissue has healed. And this would be what the definitive prosthesis was if we liked how this came out, which we did. And that's what I got for you. So what are we replacing? Consider all this stuff: patient expectations, any adjunct procedures, any existing limitations, health, smoking, diabetes, blood dyscrasias, alcohol, recreational drugs. These are all points against you guys. I don't care what anyone does in their social life, but if I'm their surgeon and I know that they're going to be doing this stuff, it's something to consider. And by the way, there's a lot of new studies on vaping now. That's not good either. Number of implants, final prostheses, the implant positions, and of course we spoke about AP spread. So we are almost an hour and 45 minutes in. Have your end goal in mind. Remember, think about the teeth that you're going to be providing this patient. If you go back here, I want to show you guys something right here in this image. That lower blue wax up that was done by Jimmy, Dr. Jimmy over at 3D Diagnostics. We did the wax up and then he scanned it. That's exactly the PMMA that you see above it. So everything just fit in like a glove. Okay. All right. So we went through this already. Let me get through this pretty quick again. Okay, so know where you're going, guys. Know the end before you begin. Now, I'm not really a big self-promoter guy. People always ask me stuff when I do interviews or webinars or whatever, and I just 1 word or 2 words and then I go on. But I do teach a course, and every attending doctor gets a full mouth of this to themselves with 2 mentors and 4 lab guys. And it's incredible. You can go to Engel Institute. This one's called Mentoring 4, and that's pretty much it. That's it. Okay, so this is where you can catch me on Instagram. It's a lot easier. I'm just telling you, it's easier for me to respond there. If you want to look a little bit into the Institute, you can go to Engel Institute Dental Implant Training and also engelinstitute.com. We do a lot of really great courses. I want to thank 3D Diagnostics. I want to thank all of you for sitting with me this whole time. I hope I made it fun for everybody. I love this stuff. Thank you very much for giving me part of your afternoon. Dr. Frank's going to come on and talk about the code. So guys, thanks. Be well, stay safe. We'll get through this soon. Peace.
Thank you very much, Dr. Engel, for the fantastic lecture. Now, before Q&A, allow me to add that I was very fortunate to attend Mentoring 4 in January 2020 in the Engel Institute. And I believe Dr. Engel had 12 full arch media conversions ready to be done, 6 of which were denture conversions, and 6 were immediate PMMA hybrids done by 3DX. And I can easily say that most, if not all of us attending, learned in 4 days in the course what we could have learned in a couple of years practicing. So thank you for that, Dr. Engel. And for everyone attending, please check Dr. Engel's upcoming courses on www.engelinstitute.com. Dr. Engel, I have some questions for you.
Okay. Frank, did you want to give the code for those people who might be splitting?
Sure, of course. And now regarding your CE credit, it'll be 2 CE credits today for the 2 hours. And it'll be 10. So T for Todd, ENG for Engel, 02. So 10, G02, TENG02, and enter your AGD number if you are an AGD member. We'll leave it blank if you're not an AGD member. And as mentioned before, an email will be sent to all attendees with your CE certificate. Now to the Q&A. Dr. Engel, still there? All right. Now, a patient only wants to do 1 arch and has perio issues. Is it worth taking a risk with the implant placement for the other arch? Or best to, number 1, get perio in control, or number 2, edentulate before any implant placement?
Yeah, it's a great question. And there's several different really good ways to approach it. You know, what I'll do is I will tell the patient that it's not ideal to do 1 arch at a time. In fact, if you recall, you know, I showed you that full arch case where Andre had quite a problem with the bottoms as well. But what I told him is that I am going to design top and bottom together. Because I don't want to make a new arch of gorgeous teeth to oppose a mistake, the opposing arch, right? So I don't want to work with a reverse curve. I don't want to work with super eruption of teeth. So what I will tell them is I will design the case in whole. If they choose to do 1 arch at a time, and a lot of my patients do that, I shared a couple with you today, that their bite might be something that they'll never feel is exactly right, but it will be protected. So you can do 1 at a time, but please tell them that you're going to design the whole mouth together. And so they kind of have to commit to ultimately doing the whole mouth. Otherwise, the occlusion might not be on. Okay, that's first. Second, regarding perio, what we know by a lot of studies is that implants last in periodontally compromised patients. So I don't necessarily know that I would pull all the teeth out, control perio, etc., if I'm going to go through a case like this where I'm going to do 6 millimeters of bone reduction surgery, tissue removal, etc. So I think when it comes to a periodontally compromised patient, I want to look at a couple things. Do I feel it was genetic, or do I feel it was neglect? Okay, if I feel it was genetic, the conversation with them will be a little bit like, you know, you will continue to lose a little bit of bone throughout your life. And we just have to watch this. We have to make sure that we maintain you, that you're on good hygiene protocols, etc. This is something that we can't always control. And we know that implants continue to lose bone, albeit a small amount. Now, if it is a neglect kind of thing where they have perio because of neglect, and a lot of my patients do, I explain to them that, you know, this is an easy thing to deal with. I would much rather deal with a neglected perio patient than a patient that is genetically just lost a ton of bone, because you can't always stabilize that with implants. But the neglected patient, I make it very, very clear, listen, you know, you're going to get a second chance at this, but this one has to be treated very differently. If you don't take care of this, it's going to go just like your teeth did. Please don't get the false sense of security that you're paying $25,000 to never brush and clean your teeth again. So that's kind of like a long-winded answer to a tree of a question. It's a great question. The other thing is, I think that, doing the number of these that I do, I find that getting them in, trying to hit the home run at once would be a lot better than staging them through a denture.
Thank you for that, Dr. Engel. Second question is, which is a pretty interesting one. How often do you remove the hybrid for maintenance and cleaning them, and how much do you charge?
Yeah. So Couple things. Screws. When labs work with screws in the laboratory, screws go in and out and in and out and in and out. Okay, so if they're working on something like a zirconia or a porcelain or something, which is glass, tightening and unloosening these little tiny screws, or fleas as they call them, it's glass is sandpaper. Okay, so as you go in and out with these screws, you're essentially sanding the screws down, and the last thing that you want to happen to you is screw breakage. So to answer the question, we charge $350 an arch. We do it once a year. We take it off and we replace all new screws.
All right.
And there's an insurance code for that, and I think insurance covers it once a year, if my memory serves me correctly.
Thank you. So another question is, what do you immediate load with D3 bone and 15 Newton centimeter torque? If not, what is your minimum requirements to immediate load?
Yeah, great question. So here's the thing. I don't look at it so much as the type of bone, okay? Because I'm not worried about type 3 or type 4 bone. Meaning, like, if the question's posed to me, well, how do you feel about loading in type 4 bone? You know, for me, it's not so much where the bone is as much as it is what did we do to customize the prep. So in other words, with all of my pilot drills, I use my pilot drill to assess what bone I'm feeling. How does the bone feel? So I can take a 2.2 millimeter Straumann pilot drill and I can feel, what does it feel like? What's the resistance like? And maybe with my next drill, I'll only go in halfway down, yet I'll put an implant in that's 4 sizes bigger, and I'll use, I'll condense the jaw rather than remove bone. So the first part of the question is, it's a lot in how you prep, and this comes with experience, and you need to use your first drill to assess that. Don't always feel, and 3DDX is here, and I'll say to them, they give you a computerized formula of how to go from A to Z, but that doesn't mean you have to do that, right? I under prep a lot of maxillary cases. So one, feel what you have rather than the bone type, feel it and see what you need to prep, okay? Check the resistance. Number two, I highly, highly recommend that if you are less than 30 Newton centimeters, that you do not load a posterior implant or an anterior implant. The lateral ones, the in-between ones, that's not a problem. But a lot of people nowadays are saying, well, you need 120 Newton centimeters an arch. And that's fine. There's that holds water. But the problem is if number 3 is gone in at 15 and everything else went in at 40, well, that 3, you're going to get some compression on 3, and that implant's going to work its way out. So how I do it is I try with every just bit of knowledge that I have, to, especially the back, is to under prep them. If I get to the point where I get a lot of torque on my anterior ones and I don't get so much torque in the posterior, number one, I'll tell a patient beforehand, there's 2 or 3 or 4% that you might be walking out with a conventional denture. It really all depends on how your bone accepts these implants. And I put the blame on them. And that's just how I say it, right? And so you have to talk about that first, and you have to have a denture sitting. Now, if I got torque on 5 out of 6 implants, and the one that I didn't get torque on was towards the back, I would cut the PMMA, or I'd cut the denture short, and I would bury that last implant. I've had a fair number of patients that have a molar on one side and one bicuspid on the other, because I just cut it off. Yeah, you want to make sure that those forces are balanced. My recommendation is 30 minimum.
Thank you, Dr. Engel. What burr do you use for gross bone reduction? And what was the blue resin used for the intraoral jig called?
So the burrs that I use, Salvin Dental, I get a bone reduction burr kit, and it comes with a circle, it comes with a pear shape, it comes with a couple different types. There's some companies that sell some that have very aggressive flutes. And what I have noticed is it really rattles. And if your patient is not asleep, that's a very uncomfortable sound and feeling for everybody, because you can't control your hand, because it's kind of like driving a tractor, or a tractor? Yeah, a tractor, where it's just bouncing. So I like the pear shape and the round ones. The material that I used, it's Prima Cure. I'm sorry. I'll get it for you right now. Go ahead, Frank. Next question. I'll come back with that question.
Already.
Look up because
Sure thing. Interesting question is, first of all, congratulations for your wonderful presentation. I would like to know, what is your opinion and experience about dynamic guided implant placement, navigation, in other words?
Yeah. So the product is from Ultradent, and it is called it's just Prima blockout resin, blue Prima block, but you can use anything. Okay, so dynamic implant placement. I think it's great. I mean, I think it's great. I think aluminum baseball bats are great. I think wooden baseball bats are great. I think, you know, a canoe is great and a kayak is great. Here's my thing. I think that dynamic implant placement is definitely an important sector of our platform of dentistry. I feel that for all of the good things that it has, I think that it also has a lot of other things to be cautious and conscientious of. So what am I saying? I'm saying that I think it is really, really sound. I've looked at some myself and been approached by some of those companies, including the robotic ones. My feeling is this. I teach what I feel is capable to the average surgeon. And I know that might sound weird, but I think that before, this is just an opinion, okay, before someone engages that all the time, all day in every surgery, I think that you need to ride the horse bareback first and really understand what bone feels like, how does tissue grow, how to flap extensively like that, all of these things. Because my opinion is navigation surgery is incredible. Frank, I know that you and I played around with that as well. And I think that that's definitely where this is going, no question. But I want to make sure that we don't remove the fundamentals of the actual procedure itself, right? Okay, that's.
All right, can you explain the difference between doing a soft reline versus a hard reline for your dual scan protocol?
Sure. So patient comes in, patient wearing a denture, any denture. What we'll do is 1 month before we do the surgery, 1 month we ask them to come in, because if they're not going to come in for, you know, we want to get it close to the surgery time. So a couple weeks even, 2 to 4 weeks, we'll have them come in. And what we're going to do is we're going to use Mucoprin soft denture liner. And we are going to do a soft tissue reline. We're going to put the material in the denture. We're going to massage down on the top lips, up on the bottom lip, create a really nice bone, trim that. And then what we're going to do is we're going to put glass beads on those, scan the denture by itself, and then scan the patient wearing the denture.
Right. What is the metal cheek retractor called that you use? Sorry, I missed these slides, so
that's okay.
wasn't able to answer the question.
Salvin, I cheated on that one a little bit. Salvin has a photo retractor. It's actually, you take it for photos and it pulls the cheeks away. And I use it for photos, but I also use it for impressions because you could pull the lip away and it's almost like having 3 hands. So I'll pull the lip away and then my assistant will hand me the impression and I'll put it in right over it and then push down my impression and slide out my retractor. So it's salvin.com and just, it's a photo retractor. I don't think they're more than 40 or 50 bucks, 40 bucks.
All right. Do you bundle your implant surgeries or restorations? And if yes, how do you go about pricing generally?
Yeah. So, so guys, there's a lot to be said about bundling. The way that we do it is we do bundle, okay? And the reason that we bundle is because there are so many parts and pieces to all of this that it's almost like sending them home with a list of everything that you're going to be doing. It actually confuses them even more, and it makes them relinquish the will to want to do it. So we do a bundle, and the bundle comes with everything. So like Tanisha, extractions all the way to the end. And we have one fee for anything of this nature, and then we have another fee that's a little bit higher if we're going to be doing individual crowns on some type of bridge.
All right. Was last patient's final prosthesis a PMMA or was it still a provisional prosthesis?
Yeah, good question. So we pre-COVID, we went to her final PMMA. Thank you. That's a good compliment. It was the PMMA. So what I'll typically do is I will either do a denture conversion, or I've done several prefab PMMAs with 3DX, and I'll do all the surgery and I'll put them on, and then I'll see them in 4 months, and I will take off the provisional, clean everything, and I'll look and assess the abutments. Are they too supracrestal? Are they too subcrestal? How did the tissue heal? And if I need to, like if one is 2 millimeters supracrestal, then what I'll do is I will change that for the definitive prosthesis and take a new impression, and then I'll put it back, the original one, to hold the PMMA that they came in with, right? And then what we'll do is we will set off the impression with the jig and have the second PMMA made. And the PMMA, as I tell the patients, it's a test drive for what the definitive will be without committing to the definitive, right? So just eat with it, do everything you want, evaluate it, look at the color, look at everything, and test drive it for 3 or 4 weeks. And if everything's good, they don't have any air, they don't have any whistling, their pronunciation, phonetics, aesthetics, all that's good, then the PMMA has been scanned. We'll just call the lab and say, okay, go for the real thing. And then they'll come in and we'll just swap them. So yeah, so PMMA or denture conversion at time of surgery, and then 4 months later, we go to a more definitive tissue hugging PMMA that will represent the real one. And if I have gaps or something, we'll just pick up an impression and send it back and have them fill in the gaps.
All right, one final question, Dr. Engel. Great presentation. Do you provide occlusal guards after the treatment?
Always, yes.
Always.
So we do. I'm going to use a maxillary occlusal guard, and this is in the bundle. Guys, if you put the night guard in the bundle, also put a water pick in the bundle. Just, you can get a water pick, cheap, 29 bucks. Just throw it in there and tell them that it is their job to water pick at least twice a day. And just make it a part of that package. It's raise your fee $50 if you have to, but put it in there and just talk a lot about the maintenance, right? Because that's important, very important. I see patients come back after a year and they have so much plaque buildup. I just take it and show them. I say, you know, this is acrylic, but this is bacteria, and it's going to kill the acrylic. It's going to weaken it, and this is going to break. So my initial surgery disclaimer / informed consent says that as long as you do what you need to do, I can help you. If I have 75 people out there right now in PMMAs and they're all, you know, smoking and drinking and not brushing their teeth and all these other things that are detrimental to surgery, how am I going to control that? So it's like, you do what you say and I'll do what I say, because a lot of patients come in and go, okay, I'm ready to drop 25 grand, make it perfect. And I don't want to worry about anything from this point on. It's not how it works. It's a combined relationship and commitment from 2 people that are responsible for 2 different parts of this. Yep.
All right. Now, one quick thing regarding CE, because a lot of people are asking. It'll be 2 CE credits, and please go to 3ddx.com/CE, and the code is TENG02. So TENG02, and then enter your AGD number. And whoever misses the code, an email will be sent to all attendees with the CE certificate. Dr. Engel, any final words?
Yes, I'm waiting to meet you guys on Instagram. Come on now. A lot of you have come on. That's awesome. Yes, my last departing words is this. Know that the time that we're going through right now is uncertain for everybody. It's the first time in mankind that the whole entire world feels everything together. So there's a lot of empathy and a lot of understanding. It is affecting everybody. So during that part of your day where you may get down and you may get frustrated and you may get fear, just know that 24 hours will change that. And this too shall pass. And you're not alone. I'm not alone. We're in this together. But the one thing that I've learned is this: I hate what it's doing to man, or woman, but I love what it's doing to mankind, because I think it's going to create a lot of compassion for all of us when we have our freedom restored. And I look very much forward to that. I miss what I do. I'm going to post a case a day. I have been on Instagram, and they're learned cases. They're not cases to show you how good I am. They're cases to help you learn the one-offs, the things that, oh, that's interesting kind of stuff. So that being said, I want to again thank you. Frank, thank you for doing such a great job. I can't wait to see you, buddy. And all my 3DDX pals, thank you for being so great. And for all of you who stayed, a lot of you stayed, thank you guys so much for giving me your mid-afternoon. I really appreciate it, and I hope you enjoyed it. All right, guys, take care.
Thank you, Dr. Engel. We appreciate you. Have a good one. Stay safe, everyone. Thank you. Bye-bye.